Rationing is a practice or policy of intentionally creating scarcity. With respect to medical care, rationing is the intentional denial of medical interventions known to be medically appropriate, beneficial, and available. Typically, this now occurs for the sake of limiting expenditures, and increasingly for the sake of being profitable. An example of rationing to reduce costs was that of routinely limiting women who had given birth to a hospital stay of 24 hours. So egregious and unjust was this practice that the federal government thankfully intervened to base the time spent in the hospital upon the judgments of physicians. This is but one of many instances of rationing associated with for-profit health care in the United States. Disturbing as this quest for profits may be, alas, one can take no comfort from the practices of governments around the world. The acceptability of rationing has eroded the quality and availability of medical care in countries lauded for providing universal access to health care. In Canada, for example, governments, federal and provincial, do not provide enough money to meet the actual medical needs of their people. Waiting lists for care are precariously long. Some people die because they are so long. Emergency care has become scarce enough to result in deaths previously preventable. In Great Britain, individuals over 65 are denied care from which many could benefit. Again, this is largely because of limits placed on expenditures. Rationing, as a matter of government policy, means that even where access to health care is universal, actual care, including life-saving care, is sometimes denied and sometimes made unavailable. Rationing was also inherent in the health care plan put forward by the Clinton administration. One example of this was the formula proposed to keep all insurances uniformly low. Subsidies for a state like New York, with its considerable populations of needy individuals and groups, would be phased out in 5 years. In 5 years, New York was slated to have the same low insurance premiums as a state like North Dakota. During the time health care reform was being advocated in Washington, proposals in the literature generally condoned rationing. Many spoke of guaranteeing some kind of decent minimum of health care. This way of thinking takes for granted that health care should not be exclusively based on medically diagnosed needs. Rather, medical costs should be limited by withholding or making unavailable some medical care, however efficacious. Rationing health care is a direct repudiation of the moral traditions that have guided Western medicine for nearly 2,000 years. How could this be happening? Why now? What can and should be done about rationing health care, this new injustice and threat to sustaining a medical ethic worthy of the name? To address these questions, it is necessary to discuss and analyze first the traditions that undergird the moral imperatives of medical practice. Secondly, the changes that subvert these medical imperatives. And third, the practical and ethical alternatives to rationing health care. Now, before taking up these topics, a brief word of clarification is in order. Rationing, as I'm using the term, refers only to the deliberate creation of scarcity. Medical resources are otherwise scarce in a number of ways. To accommodate patients, it's routine to schedule appointments for non-emergency care. In a national disaster or even in a single accident, some individuals may die or suffer permanent harm because a sufficient number of physicians and or nurses and or medical supplies may not be assembled quickly enough to treat everyone in time. In emergency rooms, those most immediately at risk of dying may have to be treated while others wait. So long as the criteria reflect medically diagnosed need, such exceptional deviations from queuing do not violate justice, given the unavoidable scarcities involved. None of these practices constitute rationing as I am using the term. It would be a case of rationing if, for example, a hospital administration or legislative body would knowingly underfund and or understaff emergency care or other care in a particular hospital or region, and that is going on. Now to the consideration of the ethical traditions of medical practice as they arose in the West. They are, as we heard once before in this conference, these moral imperatives, they are a blend of Greek, Jewish, and Christian traditions, these moral imperatives of medical practice. At around the 5th century BC, or as we now say BCE, there is evidence that the healing art began to break with its roots in religious practices. Skilled tradesmen with growing knowledge and skills to maintain health and cure diseases offered their services in the marketplace for a fee. Citizens received better services than slaves. Abortion and assisted suicide were widely accepted practices. Excellence in performance was the standard governing these healers. At the same time, however, a school of thought and practice developed that bore the name of Hippocrates, a leading physician of that time. Not only did the Hippocratics increase empirical knowledge in medicine, but they also developed an explicit medical ethic. Excellent skills were not enough. Skills can be used for good or evil. The Hippocratic Oath prohibited abortions and providing poisons to end life, and called upon physicians to be just, avoiding all harms to patients. Christianity adopted this oath, except for the references to the Greek gods and the promise to give medical education only to one's own sons. But beyond this oath, Christianity and Judaism significantly changed the moral structure of medical care and of the physician-patient relation. The Hebrew prophets, as biblically portrayed, healed the sick free of charge. Jesus also healed without charging fees. And during that time, some healers did charge for their services, because one woman, it was said, had spent all of her substance seeking a cure. Isn't there anything new under the sun? She needed free care desperately, and Jesus graciously obliged her. Additionally, there is the biblical model of the Good Samaritan. He is the good neighbor who takes the half-dead victim of robbers and takes him to an inn and gives him care there, something I hadn't noticed before. Not only does he pay the innkeeper for additional care in his absence, but he also puts no limit on the amount and cost of the care. While paying the innkeeper, the Good Samaritan tells him, quote, "Take care of him, and when I come back, I will repay you whatever more you spend." No cap on expenditures there, and the need for care determines cost. Christian and Jewish physicians made it the norm to treat everyone, however needy and however poor. The marketplace did not dictate practice or intrude into the physician-patient relation. Secondly, in accord with biblical traditions, everyone was to receive the same treatment given similar needs. No one was regarded as of unequal worth. Medical need and medical capabilities, not money, were the standards for the care given and for who it was that received it. Justice, that is what we owe one another as human beings as applied to medical care, consisted in at least the following three moral imperatives. First, the responsibility to rescue. That is, to save human life and to prevent or remove threats to it. Secondly, the responsibility to nurture. That is, to protect human life, health, and well-being. And third, the responsibility to treat people on the basis of medical need and equal worth so that no one needing care fails to receive it and receives it in the amount and quality needed to benefit the recipient. As long as these moral imperatives guided medical care as absolute requisites of its proper moral structure, the economic question was one of asking how to pay for medically indicated beneficial care. Moral responsibilities framed the question. Money was not to determine what health care, how much of it, and to whom it was provided, as increasingly it now does. Some of the current practices of for-profit managed care organizations are putting medicine back on the road to the medical marketplace once dominant in ancient Greece when medicine was one business among others. What is driving medicine backwards down this long abandoned road? It's not new, folks. We abandoned this once on the basis of our convictions. And we dominated the whole profession with those convictions. We, our long historical connections with our brothers and sisters. That's the we. What is driving medicine backward? What is it that has shifted the imperative to care toward the imperatives to save and make money and to do it by rationing care? What has changed? Well, I'm sure this is not in any sense a complete answer, but I do want to highlight a few things that I see that have changed that have a corrosive effect on the moral imperatives that have undergirded medicine. These four developments have become increasingly pervasive in recent years. One, third-party payers, costly medication and technology, expensive malpractice insurance, and utilitarian reasoning. Now, I think we did not realize what it would mean to have third-party payment systems. When physicians' fees began to be paid by governments and insurance companies, the payers tended to insist on similar costs for similar services. That destroyed the practice of a sliding fee scale based on the ability to pay of individual patients and families. I remember talking with a physician in the Boston area who was too old anymore to practice medicine, and he was weeping as he told me of how they took care of everyone until there was the third-party system of payments. Now, medical services then began to be treated like goods or products. The same product, same price. As though that's what it's about. And that had at least two unfortunate effects. First, services had to be priced fairly high in order to cover those who needed care, but had no insurance or government aid because the ethic had not yet eroded. As the cost of services rose, it became increasingly difficult to provide for those not covered by insurance or government programs. Secondly, having a third party pay for medical services inadvertently but seriously undermined the physician-patient relation. When physicians accepted the responsibility to provide care to everyone, including those who could not afford care, they had to know the life situation of the patient. And they were dedicated to meet more than the medical needs of such patients. Absolving the poor of the costs of medical services allowed physicians to help patients meet their other needs. Medical care, for example, could mean the difference between retaining or losing the ability to work. At the same time, when the government or insurance company pays for medical services, patients relate differently to physicians. If someone else is paying for what I ask of a physician, it takes on the character of a claim. When I am paying for a service, I relate to the physician as someone to whom I owe something. I owe a living to a physician for the labor on my behalf. In turn, the physician who is not compensated by the patient has much less reason to worry about how much patients themselves can pay, but rather how much insurance companies or governments will pay. It is tempting to treat companies and governments as rich impersonal sources of revenue, and fraud does occur. Add to the mix that the time spent in cultivating a physician-patient and nurse-patient relation is uniformly undervalued and undercompensated by third-party payers. It is not difficult to discern a significant source of erosion in the quality of medical care through the erosion of the relation of patients to their caregivers. Note sadly that patients are now often called consumers, signaling a significant departure from what should be a mutually beneficial, morally responsible relation characterized by gratitude, mutual respect, and altruism. And as Dr. Pellegrino said so eloquently, for us, charity. Love. Well, what about costly medicine and technology? Well, the path from stethoscopes to x-rays to the latest imaging techniques is on a steep slope toward higher costs. And drugs are on this same upward slope. And whatever justification may exist for the prices charged and the profits made, those who manufacture what is used as a medical service are not conforming to the traditional moral imperatives of medical care. These businesses are not attending to the ability to pay of those who need their services. These businesses do not, as a rule, share their profits with patients or the non-profit hospitals who could then better serve their uninsured or underinsured patients. The burdens of these higher costs are borne rather by physicians and hospitals and those who are required to pay ever-increasing insurance premiums and Social Security taxes. Everyone in the business of medical care should adopt the tradition of medical ethics that puts the needs of the sick first. Any business ethics worth its salt ought to have this clause in it with regard to those who provide medical services. It's not ethics yet till the sick are put first. And expensive malpractice insurance. Well, it doesn't take much imagination to know what surgery will cost at Massachusetts General Hospital, and that it'll be far more than anyone can afford. When, as I was talking with one surgeon there several years ago, he pays $80,000 a year for malpractice insurance. And I know some in Illinois are paying $50,000 and more, and I know that neurosurgeons pay even more. And need I say, will it be easy for such a surgeon, or generally feasible for such a surgeon, to offer free services to those in need of them? Consider that lawyers charge their clients a percentage of the money recovered from a successful suit. These percentages can be high. The Clinton health plan called for a cap of 1/3 of the award. A cap of 1/3 as a fee for lawyer services, but no cap on the amount of awards. This mode of payment obviously encourages large awards. And lawsuits have also led to mandatory use of expensive diagnostic tests, often in dubious or unwarranted circumstances. And so lawyers join the surging numbers of participants in the healthcare system that profit greatly from what they do without adopting, for the most part, the ethic of sharing their gains with patients. Do you know, I even heard of an instance in which lawyers took 100% of an award, but because they regarded nothing less as sufficient for their efforts, and the client, who was poor in every respect, still had a hospital bill to pay. Now, there are lawyers who still do pro bono work, but the moral imperative behind it has steadily eroded, and certainly it is not very much in evidence when it comes to its effects on the costs of medicine. The legal scholar Mary Ann Glendon at Harvard, in a recent work, has documented the enormous diminution of one of the major purposes of legal counsel. Did you know this, that the major purpose of legal counsel is to keep you out of the courts? Have you read an advertisement from a lawyer saying, "I know how to keep you out of the courts"? Well, maybe there is one. I haven't seen one. And then there's utilitarian reasoning. And this is the most threatening of all to the traditions that have guided medical practice and shaped its moral structure and the physician-patient relation itself, because it is a change in the concept of justice, of what we owe one another as human beings. Ever more pervasively, what counts as justice is being guided by utilitarian reasoning. I refer to the calculation of what ought to be done based on maximizing utility or maximizing total welfare. That's how gatekeepers are described. Rights are to be determined by what makes for the greatest good for the greatest number. The worth of life is calculable. Whether it is better to live or die depends upon an assessment of utility, particularly its ratio of pleasure to pain. But now the calculations of utility are dominated by monetary considerations. And the physician is increasingly called a gatekeeper, and as such is regarded as morally bound to consider the welfare of all patients and of the society generally when deciding whether a costly service to a patient ought to be offered. particularly when the physician judges that the chances of saving or extending life appear slim, or the quality of life preserved appears to be poor. So much for erring on the side of life. So much also for a relationship of shared, equal moral responsibilities on the part of both physicians and patients for rescuing and nurturing individual life. And if utility is to be maximized, and what has a utility includes money, offering free care counts as a net cost rather than a net benefit. Free care drops out as a moral imperative altogether. Maximizing utility also militates against treating the sickest patients in need of the costliest care. So much for the inalienable right to life of every individual. So much for the equal worth of every human being. All of this, my dear brothers and sisters, lands physicians back in the ancient Greek marketplace, functioning as tradesmen selling their wares. They tended to send their sickest patients to the temple to have the priests pray for them. Why risk failure and why engage in futile efforts? This costs you customers and money, since some families were reluctant to pay for failure. It is often said that no one can turn back the clock. Well, for-profit medicine in our day is turning the clock way back to ancient days in seeking to maximize profits and abandoning the sickest patients. Obviously, the practice of using money rather than strict medical need as a standard rations care. The standard of care is no longer solely based on what is medically indicated to heal, sustain, and or comfort patients. And there is no moral imperative to offer free care. When justice is conceived of as the maximization of utility, the moral imperative is to prohibit care that cannot be compensated. One reason for the increased dominance of utilitarian reasoning in medicine, law, and business is that it is a reflection of what is taught in educational institutions, including our professional schools. Many students learn utilitarian reasoning, few study our biblical heritage. Its concepts of justice and the model of the Good Samaritan. Many of the students who come to study with me have read Mill, but not Calvin or Jonathan Edwards. I remember one student even asking me how and where he could be expected to find the biblical passages I had assigned in an ethics course. Rationing care, medical care, is not inevitable. There are alternatives to rationing. Now remember how I'm defining it. That is the intentional creation of scarcity. That's what's not inevitable. We know, and John Kilner is going to talk about, how we deal with the scarce resources allocation that we have to deal with. With utilitarian reasoning so prevalent, and with the erosion of medical ethics, books advocating rationing as an inevitable present reality are already being published. But there is no proof, nor are proofs provided that health care has to be rationed, particularly in this extremely wealthy country. It would in any event only be possible to know whether rationing of medical care is necessary if morally justifiable cost savings were first put in place and tried. I refer to savings that do not compromise needed medical care. One reason given for the necessity of rationing simply extrapolates this from the growth of the amount of money spent in the healthcare sector. But why is growth a problem? We have the best available medical care in the world. And it's surely in part because of the money we spend. For other businesses, such robust employment and income opportunities would be seen as a boon. In Rhode Island, the medical care is still the major source of revenue for the whole state. For other businesses, well, consider the automobile industry. One could argue there are only a finite number of automobiles that can be made, bought and driven. One could talk of rationing. One could argue, as some do now relative to health care, that price rationing already occurs, and some who need cars and public transportation lack both. There are those who call for more public transportation. But as for the automobile industry and industry generally, growth is viewed as positive. Make and sell more cars, not less. Grow, don't shrink. Why then is the response to growth in healthcare services now so different? In part, it is because some of our taxes buy healthcare for others, and we don't think of any of our taxes buying cars for others. But we do not generally notice the tax dollars that support the automobile industry, the maintenance of an elaborate infrastructure like highways, for example. Insofar as public transportation is concerned, this is put on a limited budget, the consequences of which are difficult to discern. But when countries cap their budgets for health care, the tragic consequences are immediate and easily documented. Indeed, the quantity and quality of medical services are definitely diminished in such countries relative to what has been achieved in the United States. Some argue that medical resources are finite, while medical needs are infinite. One can grant that medical resources may well be finite. What do I know? But so are medical needs. They are not infinite. Most people are relatively healthy. Chronic care is limited as to incidence and duration. For goodness sake, everyone dies. To assert, as some do, that medical needs are infinite and medical resources finite is a category mistake. The ancient philosopher Zeno once contended that to move from point A to point B, you always have to go half of the distance. And then you have to go half of that distance. And half of that distance ad infinitum. Therefore, you cannot reach B from A, and therefore there is no such thing as motion. That is a category mistake. With respect to health care, the mistake is to treat medical needs as infinite and then make the obvious inference that finite medical resources cannot keep pace with them. You're worse off than the turtle. If then there is no proof for the necessity to ration health care, it is surely unjust to deny care to those who require it. But surely medical care has become very expensive. Furthermore, it's increasingly difficult for working people and employers to afford insurance, and so there are those who lack insurance altogether. Are there not morally justifiable ways to decrease costs without rationing services and without reducing the quality of care and the growth of our ability to save lives and enhance health? Yes, there are, and justice requires us to test them. There are these three kinds of policies that should be tried before anyone should contemplate rationing health care as necessary at all. First, altering practices that drive up the cost of medical care. Secondly, promoting moral development and spiritual renewal. You heard that correctly. Third, preserving and renewing the moral structure guiding health care. I mean, more nurses, less cost. Now, altering practices that drive up the cost of health care. It was in the spring of 1993, while the Clinton health care reform package was being secretly prepared without his input, Dr. C. Everett Koop suggested the following ways to save money without in any way diminishing the quality or quantity of health care and without changing its traditional moral structure. First, offering tax credits for reducing the administration the administrative expenses of insurance companies saving $100 billion. Yes, you should see the overhead for insurance companies. Secondly, conducting proper outcomes research, saving $200 billion. These are his calculations. Third, binding mediation for malpractice claims, saving $40 to $70 billion. Creating incentives, fourthly, for more primary care physicians who charge less than specialists, a saving that could be considerable. Now, these are suggestions that could begin to yield dividends fairly quickly and measurably. We are getting the use of specialists curtailed to save money, but not now always in just ways, as we know. Well, secondly, to promote moral development and spiritual renewal. There is no question that morally irresponsible behavior costs all of us a great deal in every way, especially in the healthcare sector of our communities. Think of the enormous savings in money and human tragedy that would result from large reductions in the use of tobacco, alcohol, addictive drugs, and violence. Our emergency rooms experience the results of these behaviors night and day. Inattention to good nutrition, exercise, and rest take their toll as well, and poverty is correlated with all these costly, tragic behaviors, and also with much higher rates of illness. It is encouraging to see the need for work being publicly asserted, but much remains to be done. Recently, I heard a radio talk show concerned with the rash of suicides that were going on in the Boston area among adolescents. A highly articulate letter from a despairing youngster to the Boston Globe was read. It was a plea to allow youngsters to work and so contribute to our communities. And some employers called in lamenting the regulations, insurance costs, and threats of suits that prevent them from what they would gladly do, namely teach youngsters their skills and their trades. It was heart-wrenching to learn how regulations and laws conspire to force isolation and idleness on young people. I know Christian parents who allow their children to do work that is technically forbidden by our labor laws. And I know personally what a joy it was for me to do adult work on fruit and vegetable farms while still in elementary school. I'm gardening yet. Moral education is no less important to promote healthy habits. When Nathan Pusey, a committed Christian, was president of Harvard, he defined the purposes of higher education as twofold: to sharpen wits and foster moral and spiritual development. In his view, no professor should be ashamed to speak of God in the classroom. That brings us to what deserves but does not receive the daily headlines, namely the health benefits of religious faith and practice. It has been empirically demonstrated that those who regularly attend worship services in their churches are less prone to illness, live longer, spend less time in hospitals when they are ill. The renewal and spread of our Christian faith promotes a wholesome, healthy way of life. It affirms that our bodies are the temples of God and are to be treated as such. Prayer and the state of our minds and souls promote health and healing. That has also been empirically demonstrated. Read some of the books by Benson of Harvard Medical School. Atheistic governments do not work. They have fostered deteriorating health and illness. Atheism is a failed social experiment. And we need to educate lawyers to advocate rather than restrict religious freedom and religiously sponsored institutions and organizations. And certainly the courts and legislatures should not adopt official atheism in the name of an unattainable neutrality. And now I come to the last segment of what we can do: preserving and renewing the moral structure guiding health care. Let's do it. The core of the moral responsibilities, let me remind you, that have guided health care are the responsibilities to rescue, to nurture and protect life, and to respect all human beings as having equal moral worth. For medical professionals, this includes the commitment to treat everyone who has a medical need they can beneficially meet in ways that never intend the death of the patient. No one should be turned away for lack of money or insurance. All of us can be grateful to God and to the dedicated members of the Christian Medical and Dental Society, who not only uphold the time-honored Hippocratic traditions, but who also uphold the Christian traditions by being, quote, dedicated to the service of all persons, regardless of the state of their economic resources or the nature of their illness. And they go on to say in their statement of principles, in circumstances where the cost of care is beyond a physician's own resources, being pledged to intervene on their behalf as advocates of adequate care. And I know that this same dedication is very much in evidence among Christian nurses and lawyers. And I experienced this firsthand while teaching medical ethics with a Christian nurse. She brought a panel of professionals from her hospital, the Dana-Farber Cancer Institute in Boston. And a student asked a financial manager on the panel, yes, they have them, if a certain kind of patient without medical insurance could be treated by the hospital, and the answer was no. And that prompted this quick but firm response from my Christian colleague Denise. And she said, we just treated such a patient recently. We hustled and obtained the necessary financial resources. Individuals also can make a difference. Surely then Christian professional organizations can as well. I think the current situation is so serious and so difficult for those who uphold the moral traditions of medicine that more may be necessary by way of organized efforts. Let me throw down a challenge. The Christian church and churches founded hospitals. Many still bear the names that identify their religious, even denominational roots. The term Samaritan is still in evidence. Christian professionals could organize in cooperation with nonprofit hospitals and with the support of churches, to form a network of health care and insurance policies. And these policies could be pegged to the ability of participants to pay. And I leave it to the ingenuity and imagination of Christian medical and legal professionals to think of the best ways to do this. Jesus healed the sick. Christians should do no less. Christian support for the healing ministry was never more needed. Now, let's not be outflanked and outdone by others. I have in my possession a call to action from a group that Bernard Lown is putting together. And he wants this to be nationwide. It's beginning in Massachusetts. Bernard Lown is the one who won the Nobel Prize, the Nobel Peace Prize, for his organization of physicians against war and against nuclear war and the like. He was on a peace mission and organized physicians for that cause. Now he's organizing physicians, and he's organizing them to save the medical profession from what he calls the mounting shadows that darken our calling and threaten to transform healing from a covenant into a business contract. And he has over 1,000 Massachusetts physicians already signed on and giving money. And one of the things that they want to do immediately is to get a statewide moratorium on for-profit takeovers of hospitals, insurance plans, HMOs, physicians' practices, and other healthcare institutions, pending the development of comprehensive state and national policies addressing these issues. So the march is on. And it's interesting that when they state their principles, one of their principles is that health care must be a right for all, and that one of the things they're going to do is have a national convocation to formulate a caring vision true to the community roots and Samaritan traditions of American medicine and nursing. Let's not be left behind by these dedicated physicians. Let us also, as Christians, rise to the need also for collective and organized action, because, as some have put it at this conference already, it's not enough to ask for individual heroics. But I know that we're all being asked, and you are being asked, for just such heroics, and you will have to say no or compromise your Christian faith in the present climate for some of what you are asked to do. It would greatly help, as I close, it would greatly help to begin to educate the public and the businesses involved that businesses or professions contributing in any way to medical care should be guided by the traditional moral imperatives of medicine. That means finding ways to share profits with patients and reduce costs as much as possible for technology, legal services, and the like. This is a special area. This is not an area for profit. This is for the sick. In conclusion, none of us should forget that when medicine is practiced as it should be, it is in itself cost-effective and efficient. Professional moral standards are incompatible with unnecessary surgery, faulty and excessive resort to antibiotics and other medications, and encouraging morally and religiously responsible behavior is a powerful way to prevent illness and the stress that triggers illness. Each of us as Christians and members of churches should exhibit the moral responsibilities that sustain the moral structure of medicine. We should not allow ourselves to be trapped into the utilitarian reasoning that sanctions the rationing of health care for the sake of saving or making money or for any other reason. It is still true. No one can serve both God and mammon. May it be said of all of us that we live in the manner articulated long ago by Joshua, as he warned the Israelites against following false gods. As for me and my house, we will serve the Lord. Thank you.